Hello, and thank you for joining us today. I'm Dr. Tara Schwetz, the NIH Deputy Director for Program Coordination, Planning, and Strategic Initiatives. We're just delighted to be here today. As many of you have likely seen, yesterday, NIH announced the launch of a new initiative to pilot a national primary care research network that integrates clinical research with community-based primary care. And this initiative that's titled Communities Advancing Research Equity for Health, or Care for Health, seeks to improve access to clinical research to inform medical care. This is particularly for those in communities that are historically underrepresented in clinical research or underserved by healthcare. Now, we announced this yesterday with a press release, including this quote from HHS Secretary Becerra, that clinical trials should reflect the diversity of Americans, because we know that delivers the best results. And we're taking a big step towards ensuring communities that are historically underrepresented in clinical research are fully included and have the same access to the best available results and analysis. And there has never been more potential for progress than we have today. It's a really impactful quote from the Secretary and supports the idea of the importance of this network that we're launching. So coupled to this news release was actually a publication of an editorial from NIH Director Dr. Bertagnolli in Science that outlined her vision for the initiative. And we're going to hear a little bit more from her in just a minute. And that this whole network is really what we're here to discuss today. So we're pleased to bring you all together to share more on Care for Health and hear from you all about how we can best serve all parts of our community, recognizing the heterogeneity through this initiative of Care for Health. Now, first, we'll hear from NIH Director Dr. Bertagnolli. Then we'll hear Dr. Joni Rutter, who will review the insights from a series of listening sessions that we had with care providers, patient advocates, representatives from community organizations, hospital systems, research networks, and other federal partners. And we are so grateful to all who dedicated their time to share their perspective, both then and today. And we know it's going to be important to keep listening and seeking feedback as we develop this network, because that's going to be such a critical component. And we'll have an opportunity, too, to hear from some of the listening session participants, as well as take questions from folks in the audience, including during two panel discussions. Now, Dr. Amy Patterson, who is the Interim Scientific and Medical Director for Care for Health, is also going to provide an overview of the next steps for this initiative. And then finally, we'll close things out with an additional period for audience questions. Now, before we begin, I just want to note a few housekeeping notes. We want to try to minimize background noise and potential disruptions, so all microphones are going to be muted except for the speakers and the panelists. If you want to contribute during the discussion, please use the Q&A feature. Questions can be submitted anonymously if you so choose, and will be answered during the panel discussions and the open QA. I want to make a note that we will try to get to as many questions as possible, but given the large attendee size based on the about 385 people that are on right now and the many, many others who also registered, we may not have an opportunity to address every single question, but we'll try to do our best and try to address those that cover multiple different people's questions. Now, today's public workshop, as you heard at the beginning, is being recorded. And following the conclusion of the workshop, the recording and the slides will be posted on the Care for Health website. So now I am pleased to introduce Dr. NIH Director and Dr. Monica Bertagnolli to share more about her vision for the program, which she has driven as one of her major priorities for the agency. Just a little bit of background on her. Dr. Bertagnolli is the 17th director of the National Institutes of Health, the first surgeon and the second woman to hold the position. And she previously served as the director of the National Cancer Institute and was the first woman to hold that position. And before that, she was a surgical oncologist at Harvard Medical School. And throughout her career, she has been at the forefront of the field of clinical oncology, studying genetic drivers of gastrointestinal cancer development and the role of inflammation, and has been a leader of clinical trials and clinical trial networks, and has championed collaborative initiatives to transform the data infrastructure of clinical research. So with that, I will turn it over to you, Monica.
Oh, thank you so much, Tara. And sincere thanks to all of you who have joined us for this webinar today. We are so grateful for your participation and your interest in this new program. And so I'm going to take you through an introduction that goes over the rationale. Why are we doing this? Next slide. At NIH, our mission is to seek fundamental knowledge about the nature and behavior of living systems and to strive to apply that knowledge to improve health for all. We support basic, translational, and clinical research to do this. And as the world's largest funder of biomedical research, NIH has supported tremendous scientific progress over the past decades. We rightly celebrate our successes, but we need to remain humble in the face of human suffering and approach our work with a continual sense of urgency. Among our guiding principles, the very first one is that our work is not finished when we deliver scientific discoveries. Our work is only finished when all people are living long and healthy lives. Next slide, please. NIH research encompasses the laboratory, the clinic, and very important, the community, all communities. The people we serve are our partners in discovery. And while fundamental science is critical and the basis of all we do at NIH, we must become more effective in connecting what we learn to clinical practice. As we grow to understand the interplay between the genes we inherit and the environmental and societal factors that surround us, beginning even before our birth, we need to connect that knowledge to everyday life and clinical practice. We need to make sure that biological insights identified in laboratories are applied to improve the circumstances of real people. Our clinical research needs to be efficient, inclusive, and responsive to the needs of patients. Next slide, please. And we also have great opportunities because we know that progress is accelerated when advanced scientific methods, such as new data analytics, are applied to data that include everyone. And when new discoveries are rapidly and equitably adopted in clinical care. New advances in information technology and data science, while familiar to many researchers, have captured significant public attention due to the arrival of large language models that can be used by anyone. And our knowledge and technology have developed to the point that we should be able to deliver evidence-based, data-driven healthcare to every person, and also have observations from clinical care returned to inform our evidence base. Artificial intelligence and machine learning are revolutionizing what is possible for biomedical research and clinical care. But if we're going to realize the potential of these new technological methods, we need to invest more in a secure and sustainable data sharing infrastructure. Next slide. And we have urgency in this mission. I am deeply concerned about the overall health of the US population. It is not as good as it should be, and we're not on the right track in many ways. Next slide. Life expectancy in the United States is low compared to our peer nations. This is not just because of the pandemic. Life expectancy actually started declining in this country in 2014. And as this graph shows, our life expectancy is low compared with other rich nations, and it's lower than some considerably poorer nations. And this is even though we spend much more. The health of the average US person compares poorly with that of the average person in many nations. And health disadvantages are even greater in segments of the US population that are medically underserved, including those who are uninsured, belong to certain ethnic and racial groups, or live in rural locations. Next slide. So what should NIH do? We need to harness research knowledge to better guide and achieve more equitable clinical care. Large and important segments of our population lack access to opportunities to participate in the research that makes better care a reality. The same people who are underrepresented in research are often those who lack good access to medical care and are disproportionately affected by disease. Participation in research needs to fully represent everyone, and especially those at higher risk. And so the evidence base we gather is more clinically meaningful and can truly inform care of our entire population. So we need to invest in our research infrastructure to expand opportunities to participate in clinical research to many more communities. Next slide. With Care for Health, we want to engage care providers and patients who are on the front lines of health in developing ways to improve interventions for common challenges, such as metabolic disorders, substance use, and mental health, and to better prevent diseases as well as to treat. We need to reach people where they are, and we believe the best setting for that is in where they receive their primary care. Unlike most research settings, primary care is patient and community-centered. Research shows that primary care accessibility is associated with fewer disparities in health outcomes, and having more primary care physicians in a community is associated with lower mortality in that community. By connecting biomedical research to primary care, we can better engage all communities in research, including underrepresented ones. We can increase research capabilities and efficiency with innovative study designs that address common health issues, prevention, and implementation relevant to individual communities. These approaches can include pragmatic trials, platform protocols, cluster randomized trials, and observational studies with data analytics. We have lots of opportunities and options. And we can support primary care providers, allowing them to both contribute to knowledge generation and to also receive information in return that will help them deliver better care. Ultimately, we want to build a more durable, reciprocal connection between research and everyday clinical care. Providers should be able to select what is most relevant to their practice and the people that they serve from perhaps a menu of active research protocols, allowing them to do the research that is most meaningful to their patients and their communities. Recognizing that healthcare providers face heavy demands on their time, we can use electronic health records to engage people in research better with their permission and reduce the burden of data collection. Patients can choose to opt in to have their medical records tracked for observational research to understand their condition, their disease, how their contribution can contribute to our knowledge. And they can also decide whether they want to be contacted again about future clinical trials that might be relevant to them. If their records indicate they would be eligible for an existing trial, they can also be contacted with information about the trial and asked if they would like to participate. We want to respectfully engage people. Ultimately, we expect that we can create a nationwide learning health system in which research and insights from patient care constantly inform one another. Next slide. So we're preparing for our launch. We had listening sessions. I want to say that the NIH and the Foundation for the National Institutes of Health hosted a series of listening sessions to gather input on how to embed clinical research in primary care settings. And I want to acknowledge the Foundation for NIH for their great partnership in developing and running the listening sessions that have informed this workshop. And I must thank the listening sessions participants for their time and critical input. We had engaging discussions with participants from patient and community groups, with primary care providers to learn how we can support them to achieve this work, and representatives of hospital systems, research networks, and other agencies. And it was invigorating for us at NIH to hear their perspectives. These discussions highlighted the ways in which NIH and the research we support can shift our engagement with Americans who need and receive healthcare. You will hear more about what we learned in the listening sessions as our program continues. And your feedback today will also likely inform the final shape of the Care for Health program. I will just say again, we are listening and we need to learn from you how to do this critical work. Next slide. After months of discussion within NIH, with federal partners, and with the wider community to help hone and develop this new program, it is wonderful to be able to announce the official launch of Communities Advancing Research Equity for Health, or Care for Health. You'll hear more about the program over the next couple of hours. Immediately after me, an overview of the listening sessions. Then panel discussions with providers, patient advocates, and researchers on what they think success would look like for this effort. And before we close, a Q&A session, Dr. Amy Patterson will describe the planned infrastructure and operations of the program. Care for Health will allow us to connect with patients and their clinical providers to develop relationships that we hope will grow and extend to more and more communities. We will start small with a 2-year, $30 million pilot initiative. We'll start by prioritizing rewards to research hubs that can enroll and work with rural communities to help us learn what we need to be able to expand the program. We expect sites will be able to select the studies that they want to conduct. In the future, they will have a long menu to pick from based on local interests and needs. We will learn based on what studies individual communities feel are important for them to invest in, and what studies both the providers, both the caregivers, and the patients feel are meaningful to them. Starting with this small seed, we hope to build sustained relationships. We plan to build an infrastructure that also earns trust and nurtures long-term bonds so that people can see the benefits of integrating research into the care they receive and into their specific community to meet their needs. We hope that by enhancing access to research, particularly among those who have been historically underrepresented and underserved in research, we will have meaningful impact on the health outcomes that are seriously affecting them. After the first year, we aim to greatly broaden participation so that more communities throughout the country can participate. And so finally, next slide. Thank you so much for the opportunity to speak with you today. And thank you for your interest in Care for Health. And we hope that you will be able to help us learn how to help the many people who are counting on us. Thank you.
Thank you so much, Dr. Bertagnolli. That was fantastic. And hello, everyone. I am Dr. Joni Rutter. I am the director of the National Center for Advancing Translational Sciences, or NCATS. And I have served over the last few months as the co-chair of the Oversight Committee for Care for Health, along with a few other colleagues. And I hosted one of the listening sessions mentioned earlier, and I listened in on all of the other listening sessions as well. And I want to take a moment to thank all of the participants who shared their suggestions and thoughts during these sessions. There was a wealth of information gathered from these sessions, and I want to highlight some of those key insights that we gleaned and that we heard and relay them back to you. So if you please go to the next slide. Over the last 2 months or so, NIH and the foundation of the NIH hosted 4 of these listening sessions, as Dr. Bertagnolli mentioned. And these sessions were really meant to inform the planning and design of the Care for Health Network. And as Dr. Bertagnolli mentioned, this network will aim to improve research equity by enabling access to clinical research for populations that have been historically underrepresented in research. Now, across these sessions, we heard from nearly about 80 participants from a variety of fields, including primary care, research networks, patient and community organizations, and other federal agencies as well. The first session shared perspectives on patient and community involvement in research, marking really a significant step towards fostering a more inclusive environment in that research. The second session cultivated ideas on expanding the reach of research networks and identifying potential barriers that could impede clinical research participation so that we understood those a little bit more clearly. The third session focused on understanding the best practices to sort of seamlessly integrate clinical research into healthcare systems and the primary care settings. This idea of bonding those two, clinical care and research, together is truly important to us. And so this was really the crux of that. The fourth session identified opportunities to alleviate site and provider burden during this, the idea of integration of these settings, and then helping us set the stage for a more efficient and innovative research landscape in primary care. So with that, what we heard, really based on the input from all of those listening sessions, we developed an executive summary here shown at the bottom, and we invite you to take a look to scan the QR code here on the screen, and it will take you directly to our website that talks about this executive summary for these listening sessions. But for now, I'd like to relay a high-level summary here with sort of 3 main themes that emerged as key areas for us to essentially consider for developing the program. So the first was really about building connections, the importance of building sustainable and effective partnerships with communities and primary care practices throughout the life of the research project. The second theme here in the middle box was really about provider needs. So the significance of aligning research and clinical relationships, workflows, timelines, and all of these key operational activities for successful implementation of research. And then the third was sort of about cost to participate. So the necessity of the financial sustainability for the successful and long-term integration of clinical research into primary care. So more, again, is in the executive summary in this QR code, but let me get into some of the details here a little bit more broadly. So please go to the next slide. That first sort of theme about bridging gaps and building connections. This is really thinking about how to create effective partnerships. And in order to build sustainable and effective partnerships, we heard about the need to essentially address constraints imposed by sort of the funding cycles that we have, and moving away from the episodic or the quote unquote helicopter engagement, and more towards more effective continuous engagement throughout the research of the project lifecycle. We're also heard a lot about beefing up health centers and community organizations through mentorship, through administrative support, and sustained staffing. We heard about developing sustainable approaches to maintain ongoing relationships with local community partners, such as the YMCA, YWCA, schools, faith-based organizations, and we need to find ways to support these ongoing collaborations with those groups and to build and strengthen new ones as well. In the middle box, we learned that demonstrating trustworthiness through balanced and bidirectional partnerships is incredibly important. Opportunities for community members and researchers to jointly develop and shape the research agenda, from setting priorities to designing outreach materials to empowering community members as agents of change. Those were big messages that we heard. an engaged physical presence in communities with active observation and dialogue to better understand the community's actual needs is also seen as really important. We also heard about the importance of engaging and understanding communities' more diverse needs, and that's shown in the last box there on the right. There's no one size fits all here, and we need to adapt research engagement approaches to reflect the community's needs and preferences. There's also sort of a dual need to raise provider and researcher sort of cultural competency and enhance community literacy of the researchers so that they can better address needs of the communities that face historical injustices in research and medicine. If you go to the next slide, the next theme really touched on how to make research work for primary care providers and practices. This really is going to take, it's going to take hard work, and it will take new ways of thinking about how to do that work. But some high-level approaches really emerged from the listening sessions that we had. We learned that primary care providers and health centers play a pivotal role in promoting research, necessitating engagement with diverse healthcare stakeholders, such as doctors, nurses, nurse practitioners, as well as the support staff within these communities as well. And so we must provide primary care providers with the tools to be able to easily guide patients towards those relevant clinical trials. We also heard about how communication needs are going to need to be strengthened really early and often, and how we communicate those needs to engage in flexible research designs and collaborative efforts that can help mitigate health system and research timelines, misalignments of those timelines, for example, and which results are going to need to be communicated throughout these different communities. And we all know that there are differing operational and research paces that different groups go by, and we need to accommodate all of those different approaches. We also heard about, in the middle box here, participants spoke in ways that research needs to take into account existing provider workloads. Integration of research into healthcare settings must be done with essentially careful planning, understanding where limitations may be, and coordinating to ensure it fits within the clinical team's routine operations without adding to the burden of the workloads that already exist. In addition, resources and support need to be provided, such as training and mentorship, additional staff, and technology advancements that need to be provided to the clinical team to help operationalize this involvement. In the last box, innovations that present opportunities to reduce the burden associated with this research. So primary care settings provide the opportunity for new research methods to be further developed and then incorporated when exploring questions that are most relevant to direct patient care. And I think this is a very exciting component of this work. And implementing research that is feasible in primary care settings also increases the likelihood that proven interventions will successfully be implemented in that clinical practice. The use of artificial intelligence, common data models, data tokenization, and other technological approaches are going to be potential ways to simplify the research processes and reduce the time and resources needed for data collection and management. And this will take time and careful navigation, careful planning, but it holds promise to really lighten that load. Consulting with providers in the design phase of research is needed before integrating technologies such as mobile applications, wearable devices, and secure messaging systems, as not all communications and patient populations access technology in the same way, and we need to be mindful of that. Providers have valuable insight into how well different interventions and platforms will work in their communities, and that's why it's so important to make sure that we have that constant communication to be able to address those needs. On the last slide, the last theme that we wanted to touch upon is sort of this idea of balancing financial implications of research involvement, which this theme really spoke to the dollars and cents associated with research and ensuring that participation is sustainable and equitable for all involved. So to address the financial sustainability, we must ensure that funding is adaptable to meet the needs by providing flexibility in research methodologies, adjusting to changing circumstances, and tailoring interventions for local needs. We also need to be considering the revenue impact on providers and patients and explore ways to provide compensation for time spent on research. Additionally, on the right-hand side of the box, it's important to value patient and community contributions with equitable compensation. And in order to effectively sort of co-create, patients and community members should be involved in the decision-making processes, including formal roles in decision-making bodies, and their voices should be involved early in the process before research budgets are allocated to advise on research priorities and projects. And that's why these listening sessions are so important. Navigating the complexities of existing funding structures is essential to provide adequate compensation to patients and community organizations for their time, their services, their local knowledge, and participation in research. So there's really this need to update funding applications and reviews, including having greater community representation in reviews, and to better recognize applications that involve community partners. Participants also stressed the need to provide fair market compensation to organizations and individuals for their participation in research and in helping researchers navigate those local communities. And as many research centers control budgets, they need to be mindful of the compensation structures that they offer, considering how to appropriately value individual and community organization contributions. So those were some of the key themes that were discussed over the listening sessions. There were many more, but these were the really truly major themes. And so with that, these were the highlights of the listening sessions. It was an incredibly informative series of workshops, and we will continue to utilize the information that we gleaned here as we move forward with the Care for Health Network. And I want to reiterate our thank you to all of the participants who've engaged so far, and thank you to the participants who are joining us today. For that, I will turn it over to Dr. Kashu for our first panel discussion and go from there. Thank you.
Thank you, Dr. Rudder. Hello, thank you for joining us today. I'm Dr. Felicia Kashu. I am a program leader in the Office of Strategic Coordination in the Office of the Director at NIH, and I'm the program lead from the Common Fund for Care for Health as a new Common Fund program. In a few moments, I'll be joined by 4 other panelists, all of whom participated in the listening sessions that Dr. Rudder just summarized. Panelists in both panels today will discuss their vision of success for the research network that embeds clinical studies in primary care sites supported by Care for Health. Following their presentations, we will invite the audience to ask questions, so please use the Q&A feature to submit your question. Next slide. So I'd like to welcome our panelists. We'll start by asking each panelist to briefly speak to their vision of success for the Network for Research in Primary Care. First, we have Dr. Megan Stabler, the Executive Director of the Northern New England Co-op Practice and Community-Based Research Network, and Assistant Professor in the Department of Community and Family Medicine at Dartmouth Health and Geisinger School of Medicine. An epidemiologist by training, Dr. Stabler, her career has centered on serving rural communities and underserved populations through applied public health research collaborations. Prior to her role with the Northern New England Co-op, Dr. Stabler directed several NIH-funded observational and interventional research programs, including the Environmental Influences on Child Health Outcomes, or the ECHO program, for the New Hampshire Birth Cohort Study, and Improve AKI, a cluster randomized trial of team-based coaching interventions to improve acute kidney injury. So handing it over to Dr. Stabler.
Sure, can you hear me?
Yes.
Wonderful, thank you so much. This is quite an exciting time for all of us in primary care research, so we're grateful and happy to be here. So I was asked to really think about a successful network for conducting clinical trials in primary care through the lens of our Northern New England Co-op PCBRN, We're housed in the Department of Community and Family Medicine at Dartmouth Health, and we're affiliated with Northern New England Clinical Translational Research Network, serving rural patients of Maine, Vermont, and New Hampshire. So I'll frame this success by in the who, what, where, how kind of framework. Starting with the what, it looks like, or what it looks like, success is conducting research with primary care for primary care. Simple as that. But meaning pragmatic, co-produced research with actionable findings that's in line with the pillars of community engaged research principles. So these pillars are building and sustaining trusted relationships, equity and shared decision-making, capacity building. So for the co-op, that means professional development, resources, and support for clinician-driven research, and sustainability. So sustaining relationships and that support beyond a single funded project. For the community piece, for PBRNs, that means practice, clinicians, and patients that they serve. So the who, working with PBRNs early on can really help identify who needs to be at the table. And it helps us integrate primary care clinicians into the research team, not just as reviewers, or advisory board members, but really integrated into the team. And that's a huge win for us. There are champions, there are adopters, implementers, and they can uniquely identify patient providers and their clinical environmental needs that might not be obvious to researchers. We not only need to understand the who, but we also need to understand where our community is so we can meet them where they are. It's no secret to anyone on this call that primary care is under distress for many reasons. We're still dealing with the fallout of COVID, for one, but there's a workforce shortage. And what does that mean for researchers? It means that we can't expect them to do any administrative work. It'll be challenging to tap into their staff or nursing, or even asking a medical director for FTE time of a clinician for research purposes. We really need to provide the personnel, take on those administrative burdensome tasks. Financial distress. How does that translate for researchers? It means that we cannot disrupt their patient flow. No amount of research incentives will outweigh lost patient revenue, nor combat growing patient panel demands that they're up against. Also, we need to consider access into clinical settings is still limited, more so now than before the pandemic. So we have to be flexible. The clinics can help us figure out how to conduct the study within their current workflows and constraints. The key here is that the community and clinicians and patients are in control, not the researchers. So to answer the where, when, and how one conducts clinical trials with primary care patients, we ask the clinicians and staff. They will tell us. A researcher can't necessarily say that this research is pragmatic for primary care. It takes us going to primary care and letting them tell us how to improve it and how to fit it into their pre-existing flows. The best way for larger CTR and CTSAs to engage with primary care clinicians is through their trusted PBRNs. And it's really beneficial for PBRNs to work with CTRs and CTSAs. They have invaluable infrastructure in their community engagement and outreach cores, bioepistat, or biostatistics and epicores, their evaluation and tracking. They have Echo Series, community engagement studios that's incredibly helpful for practice-based research. So the key here is flexibility. Every site is going to be different with varying policies, procedures, resources, technologies, and general openness to research. So protocol flexibility will determine if the trial is pragmatic for busy and diverse clinical settings. Pragmatic designs will result in a higher chance of success. I'm an epidemiologist. I understand the desire for strict protocols, but really allowing clinician and practice level tailoring can result in enhanced effectiveness, relevance, and increased recruitment of rural underserved patients into clinical trials. Research projects never go exactly as planned. Things pop up and we don't anticipate, and we have to respond in a flexible and creative manner. While this all may sound simple and straightforward, the truth is many primary care research projects brought to PBRNs don't follow these basic principles. Aligning clinical trial selection with local interests and needs, feasible and flexible protocols, and actionable findings at the local level will result in better care, happier staff, and evidence-based research that is inclusive of our underserved populations. Thank you.
Thank you, Dr. Stabler. We are also joined by Dr. Sally Hodder, an infectious diseases physician and researcher. Since 2014, she has served as Associate Vice President for Clinical and Translational Science at West Virginia University and Director of the West Virginia Clinical and Translational Science Institute, directing a U54 cooperative agreement. Dr. Hodder, over to you.
Thank you very much, Felicia, and thank you for inviting me to be a part of this. So my view of what a successful network looks like is one that actually conducts impactful research. And what I'd like to do is to give you two examples that, in my opinion, one illustrates what I would say is not success and the other one which is. The first example is completely hypothetical. And that is an example of, let's say, a vaccine trial in primary care practices that enrolled 1 or 2 people per trial. It was a large multi-center trial all over the United States. It was a fantastic efficacy. It prevented 95% of the death. This is hypothetical, but let's just say, you stay with me here. And yet, you know, the trial network, one of them involved, only enrolled 1 or 2 people. And I think that Dr. Stabler and Rudder really discussed the components that may have contributed to that, you know, understanding community barriers to research, their notion about vaccines, you know, all of those things. And so when the trial was published in the New England Journal of Medicine, it did absolutely nothing to change how people thought about vaccines, accepted vaccines, talked about what their issues were. And I would say that is not a successful network because impactful research was not conducted. Now, successful research, let's go to a real example. And that was the HIV Prevention Trial Network 064 study, a study that looked at HIV incidence in at-risk women in the United States. This was about 10 years ago. And you may remember that, you know, at that time, much of the HIV acquisition in the United States was among men who have sex with men, though there were trials in Africa, indeed, where there was a high incidence of HIV among women, there was almost nothing in the United States. So the trial enrolled 2,000 US women in 6 urban centers. 85% of those women were African American or Black. And the trial demonstrated to be eligible, you had to live in a census tract with high poverty and high HIV prevalence. And that trial demonstrated, number one, that the HIV acquisition among women who were enrolled in the trial was 6 times that of the age-adjusted incidence in the United States, across the rest of the United States. And then number 2, those women didn't think they were particularly at risk, when clearly they were at high risk. The dissemination of that trial included a webinar simultaneously at all 6 sites that really presented the results, had participant input with some of their impressions, and then was followed in each community with a discussion, implications of this trial for the community. One of the themes I would say of that trial was the lack of empowerment of women. I had the privilege to be in Newark, New Jersey at that time. Cory Booker, who was mayor of Newark, New Jersey, actually came. We had many of the participants and other community and faith-based leaders there about what the implications were for Newark, New Jersey, and what we should do. And I would say that was a successful network trial in those 6 sites because it was impactful every place. Let me just give you the epilogue of what happened with that. This was a very activated network. You know, women were ready to go. And there was a hiatus between the NIH and industry to bring trials of HIV prevention to US women. There were years. Now we're starting to see it. But I would sort of end my vision by the fact that when we start this, we need to make sure that actually all partners, including the sponsors, are in, for the duration, and that you don't activate and have a successful network and then not really sort of provide the next steps. Thank you.
Thank you, Dr. Hodder. Now we'll turn to Mr. Silas Buchanan. Silas is the founder and CEO of ourhealthcommunity.com. Silas is an experienced underserved community engagement strategist dedicated to building equitable partnerships that solve for known outreach and engagement failure points. Silas previously co-developed amechealth.org as the official health information sharing channel for the AME Church, one of the largest mainline historically Black denominations in the world. Mr. Buchanan has also contributed thought leadership to the National Academy of Medicine, Milken Institute, and Faster Cures, among many others. Mr. Buchanan?
Thank you so much, Felicia. Thrilled to be here. And there's little doubt, based on Dr. Rudder's recap, that NIH truly was listening. I've got a couple slides. I think you have those teed as I cue them. Perfect. So asked to noodle through what a successful network for research might look like from my perspective, the community's perspective. And for us, and I can't speak for all community, obviously, but it obviously looks inclusive. It looks like a space where community-based organizations, community members, and researchers all equitably exist and understand each other's value. Meaning that researchers aren't knocking on the community's door with a $2 million NIH grant of the moment and then offering, a ham sandwich or a $25 gift card for community's participation. It looks like a network where leaders of faith and community-based organizations are connected all the time, and not just herded together based on who might have that grant of the moment. It's a network where community-based leaders are trained to understand the importance and understand their value and the value of their community members in the clinical research enterprise. And not just from a research perspective, but payers know exactly where their non-compliant diabetics are by zip code, and also need community to be engaged, and providers, of course, as well. It's a space where researchers are open also to being trained by community leaders, as Dr. Rudder pointed out, to improve their cultural competence, their cultural intelligence, and their cultural humility, to improve trust so that they might more equitably engage with community members. And it's a place where healthcare stakeholders feel good about going to community first as they plan their research and craft their budget. So at Our Healthy Community, and you see from the slide, we're building spaces where community first is not just a phrase, but it's a space where it can be realized for everyone's benefit. So to us, community first means, community is actively engaged to vet collateral materials and campaign materials prior to them going to market. It means educational content and resources are co-created with community. This will help them, meaning community leaders and members, better understand research, and it also builds trust. It means that community-based organizations can see themselves in these materials, and then they would be excited to amplify them. We know that many faith community-based organizations have social networks, Facebook, Twitter, Instagram, and they have exponential reach to community members. So if they are in the co-creation process and see themselves in the materials, when it comes time to distribute and amplify them, you want those folks to be excited to do that. And then trust can begin to blossom, and as equitable partnerships begin to emerge. Next slide. So at OHC, our OHC Engage platform is designed specifically to put and keep the leaders of community-based organizations and faith-based organizations together all the time. Again, not just based on what researcher has the need for a community advisory board just for today or maybe just tomorrow, but it's that consistency, it's the time spent. So OHC Engage allows us to create open spaces. It's a network, it's a platform, an ecosystem that allows us to create open spaces designed to put faith community-based organizations and researchers together, shortening the distance between them. But we can also create private, password-protected spaces, purpose-built just for the leaders of faith and community-based organizations so that they can connect, convene, collaborate, and co-create without researchers present. We can also build confidential spaces. So in a patients like me sort of way, We can host community members of color or underserved community members of any color that might be dealing with a rare disease or chronic illness. And we can open or connect these spaces as needed. Zoom is natively integrated through our ecosystem. Training, coursework, software is natively integrated. And also event software is natively integrated. It allows community-based organizations to go live, we'll say at a church health fair, if they want to. Next slide, please. And so here's an example. We recently established a working relationship with IQVIA to really drive our vision for equitable participation in clinical research generally. But this particular slide, we're partnering with academic researchers at Case Western Reserve University in Cleveland. We're hosting a cohort, 5 cohorts of 7 women-led community-based organizations. So this is 35 community-based organizations selected by Case Western Reserve with our assistance to partner with them to address Black maternal mortality. And in this example, you see 6 community leaders in a cohort. We're marrying them with a faculty partner and also a navigator. But importantly, at the very bottom, you see a supplier form, right? So these community leaders will be seen as suppliers. They'll be treated as suppliers to Case Western Reserve University as part of this effort. So it is our approach, we believe, is one that is inclusive and supportive of the goals of researchers, as well as keeping the interests of community leaders and members first and foremost. Again, proud to share the work, and thanks for inviting me.
Thank you. Lastly, we have Dr. Fornessa Randall, the director of the Center for Advancing Equity in Rural and Underserved Communities at the Penn State College of Medicine, and is also the current executive director for the Asian Health Coalition. She has over 25 years of experience in health systems innovation and minority and community health planning on behalf of rural, immigrant, and underserved communities. She serves as principal investigator for several federally funded programs, including the NIH All of Us Research Program Awards and from other awards from NHLBI and the ANHPI cohort study. Dr. Randall.
So excited to be here today. Thank you so much for inviting me. I think what I'm hearing from everyone in the exciting part and the challenging part about going last on the panel is that I just want to reiterate everything else everyone else has already said. So I appreciate this great panel and all of the things that were shared. I'd like to share a couple of examples since we were thinking about what integration and clinical research looks like in primary care settings. I'd like to share some examples from some different academic centers that I've been to across the country. I think that a lot of people have hit on the fact that we need new ways, we need innovative ways, we need to tailor things according to what's happening. So in New Mexico, one of the challenges that we faced when I was there is that and that the country really faces that individuals are going through the emergency room for several of their primary care really issues. And so what we realized is that the partnership with the primary health center, with the primary care health center and FQHCs across the city in Albuquerque was a way for us to be able to partner with them, utilize the advantages of the hospital, and then connect the specialists and researchers with that primary care site, utilizing some of the technology that we developed there. And we were able to really see the ability to connect people who actually had multiple issues. They weren't just they weren't just primary care, they were all the social determinants of health, right? So we realized that you have to, and we're getting that to the next point there of treating the whole person and looking at those, working with primary care centers, working as Mr. Silas has talked about with the community, and working with the researcher. We created a package that was able to really care for the patient and drive them to the things that they need to get at the right time. And so delivering right care at right time, I feel like that's really important in any sort of clinical research setting. The second thing I want to share about is some of the issues that we were tasked with in Illinois, and working with the University of Chicago there, Northwestern, our Northwestern partner as well. We were able to see that people, this was really centered around, colonoscopies and getting people in for just screening. But also, if that screening, led to, the need for treatment around cancer, and really looking again at the whole person. People may start off with a FIT test, but what we found is by creating the Illinois Care Continuum, which is a web-based HIPAA-compliant portal that links primary care providers with specialists through this web-based tool. And it's non-connected systems, but they link together in one system, which is the beauty of this whole process, is getting people through, linking people and getting patients through the process of needing care and needing screening. And so we were able to see that by linking patients from the needs that they have at a primary care setting to the specialist, and allowing them to be able to talk in a platform where they normally would not be able to, and communicate there by sharing patient information, sharing records, sharing the results of the colonoscopies, that we were able to really see how primary care, working with academic institutions, was able to really create a whole person approach as opposed to a study participant. Now, thirdly, I want to address some of the issues that we're trying to face in Central Pennsylvania through the College of Medicine, and those are really taking. I think one of the questions that came in through the Q&A portal is talking about, will cardiovascular providers be involved in this new funding that's out there. And one of the things that we're doing is we're working with cardiovascular doctors to be able to work with communities, and then work with primary care facilities to provide co-created training for community members, which is very exciting, around cardiovascular, disease, and really figuring out ways to address issues with the provider that also needs that cultural competency coming from the community, but also providing that expertise, from an academic perspective with the community members, who also then all work with the primary care provider where the patient is housed. And so we're really seeing a development of a collaboration that we're very excited about. And then finally, I want to share about our work as an All of Us research partner, a research program partner, and the ability. I know that several have shared today, and Dr. Bertagnolli as well has shared that the importance of really being able to enroll individuals who are sort of underrepresented, and as Dr. Kareem Watson says from All of Us program, underengaged population, that we are able to really work with a community partner who is also working with the researcher and working with a primary care center to be able to enroll people in this program. And so you see, again, that triad, all three working together to really be able to get clinical research involved in primary care. So next slide, please. And I'm actually going to skip the next slide, because I think it's important that we all know these things. These have already been shared about, different things that we need to do within the research setting to be able to build that sustainability. And I think the sustainability is really important. These things, addressing these issues here that have already been highlighted by many that have come before me today, will really help us to be able to sustain this process in primary care settings. And then lastly, I want to end with a graphic that sort of, shows us, what the, where we are, and what the goals of why we're doing what we're doing. We don't want these numbers. Generally, when I present this slide, you actually don't know who goes where, right? You don't see who goes where. And then everyone sort of thinks, oh, I think this number is over here, and I think this number is over here. But actually, you end up being surprised that in fact, this is why, this is where these different races are. And without clinical research being involved in primary care settings and working with the community members who actually have access to many of these underserved populations, we would really be able to address some of these issues. In this particular one is cancer incidence. So I appreciate this time today. Thank you.
Thank you, Dr. Randall. Thank you all for the thoughtful remarks and visions for our guidance. We'll now address some questions from the audience related to the panel presentations and the topic of what success looks like for providers and patients. Please submit your questions in the Q&A box, and as you're doing that, we'd like to take the opportunity to hear from you via a quick poll. We'll be collecting data from the poll to inform our answers, and you can see it on the screen there. We'd like for you to rank the motivators for individuals to participate in research in primary care from your perspectives. While you're submitting your responses, I'm going to announce that I'll be joined by Dr. Stacy Adam, the Vice President of Science Partnerships at the Foundation for the NIH, to help us navigate the questions that have been coming in. So just give it another 10 or 20 seconds for submitting a response to the poll before we jump right into the first question. All right. Thank you for your response to the poll. We will use this information to inform our planning. So over to you, Dr. Adam, for the first question for the panel.
Thanks, Dr. Cascio. Yes, we've had some lively questions coming in, and so I'm just, I will forewarn the folks submitting, I'm going to take these a bit out of order because I think some of what's submitted may be better for later panels, but we'll hop right in. There's a lot of questions, and so I'm going to take just a couple of them about how this current effort is going to coordinate with other efforts. And so I'll start by just selecting this one, that there's a curiosity question as to how this particular network will be collaborating or working in coordination with those being supported by PCORI. So Felicia, this may come directly to you or any of the panel.
Yeah, I think we'll touch on that. Dr. Patterson will touch on how we're partnering with existing infrastructures and resources. We do really want to leverage what's out there. And we do think it'll really help us get up and running quickly and just jumpstart our efforts to really learn what approaches work and don't work in our pilot years. So maybe Dr. Patterson will touch more on that in her session.
Okay. And Dr. Randall, we've got a couple of questions specifically for you, knowing that you work with the All of Us program, but how do you see All of Us fitting into this? And do you see a collaboration there?
Absolutely. I think that the All of Us research program is the foundation, really, and has really piloted and sort of heralded some of these initiatives already, with the idea of linking patient records to their their clinical, biomedical, to the biomedical research, and being able to work with communities. I am the PI for a community engagement partner that's a national partner and that has 25 members, 25 organizations in 45 states. And so our goal is really for the American, Asian, Native Hawaiian, Pacific Islander populations is to really, be able to engage them first, educate them first from trusted partners, and give them that foundation about the program, and then to connect them with community, with primary care settings, and then also then to enroll them in the program. And so the All of Us program, I feel like, is essential to this care network.
And thank you so much for that. I think you also touched a little bit upon another question that we had about, how do we envision that we are going to engage with American Indian, Alaska Native, and Native Hawaiian populations. And so it sounds like you would envision something similar to the approaches that you guys have taken with All of Us for this. So wonderful.
Absolutely.
The next question I have is for Dr. Stabler. it says, Dr. Sabler, you mentioned providing or supporting research administration staff needs. Can you talk a little bit about what that would mean, especially in the context of a network like this?
Sure. Yeah, I wasn't meaning that we would like hire folks in the clinical setting, but we would have our staff team take on the work of that research if invited into those clinical settings to conduct research with primary care providers and their staff. So really just displacing the workload, if that makes sense.
Yes, thank you. Mr. Buchanan, there's a question here. Obviously, people were very inspired by what it is that you've been able to stand up, and they were just curious if you could talk a little bit about how you got that started and built it up.
Yeah, well, you know, my wife is not in earshot, so I won't talk about our kids' college fund so much, right? But yeah, no, it's hard work and it's passion. When you recognize that historically communities are not pulled together, they're not listened to, the conversations have always been one way. So the inspiration for doing this has been over time, simply listening to community. And when you have an opportunity to let them put their guard down and you begin to create strategies that I don't want to say forces them, that allows them to put their guard down, you'll begin to collect a lot of information. And so an example, we always want to, in our conversations, we want to be present, right? Because trust is really built on time spent. So you have to spend time. You can't be in and out. So we spend a lot of time. When we're together, we always acknowledge histories of marginalization and mistrust. We always have transparent discussions about power and where it lies. We talk about social determinants of health, but we also talk about the political determinants of health, right? You can't get the bus to get to the site, but maybe there was a politician that voted to stop the bus from running into your neighborhood. So we want to have those conversations. We always want to discuss how to build on community strengths and local knowledge and encourage each other and identify opportunities for co-learning to improve, you know, community capacity building. And so it's one brick at a time, but this is where it starts. And very lastly, the things that we do are not owned by healthcare payer, provider, government, academic, life science, or pharmaceutical stakeholders. We see ourselves almost as Switzerland that kind of sits in the middle as a flywheel between those healthcare stakeholders and those community leaders that are at the grass tops, that are connected to those community members that are at the grassroots.
Stacy, thank you, Mr. Buchanan. Oh, while you're looking for the next question, I wanted to prompt for a second poll question for the audience that should be popping up on the screen. We'd like to hear from you. Recognizing patient and community engagement is critical at all points. Rank where you think in the clinical research life cycle, this network should prioritize more intentional and focused engagement. So pause here for a few moments.
Could I come off mute and just address one question that was in the chat, in the question and answers? Is that
Yep.
legal? There was one question earlier in the day about just the need for support for these primary care settings and how to really help you know, with the administrative tasks, figuring out how to, navigate and work, a clinical trial in their setting and different things. And one of the things I will advocate for is something that we're doing in Illinois, which is implementation science intervention within primary care settings. And so really working with those providers and working with those organizations and health systems to help them figure out better ways and more efficient ways to run their practice so that research can be allowed in. And really, I think that has been one of the things that has been a great success for some of the work that we've been doing in Illinois. So I would advocate for that as part of the support for these primary care settings.
Thank you, Dr. Randall. Stacy, maybe just one more question.
Sure. So I think I'm trying to, there's a lot of question about infrastructure and stuff like that. And I think that we are going to get to that as we get further into this. But I guess maybe to reach in flexibility, maybe we can take one of the questions around that, because that seems to be a topic that people are interested in. And so, everybody seems to want to understand how broad are we going to go? Who's going to be included? Cardiologists, family care physicians, all of this sort of thing. And so if the panel could speak a bit to how, even if we start here, how do we get to, the broad inclusion? And then the other thing is to talk about how we start to get to populations that may not even have primary care physicians. We've had a couple of questions around that, around migrant care, around young millennials, actually, that apparently no longer have primary care physicians. So, so the reach and maybe alternative reach for people who primary care physicians aren't their primary care.
Dr. Randall, would you like to maybe
I would love to. I was like, I don't want to talk too much, but this is like right in my wheelhouse. So I really believe that working with, we did a survey a little, a few years ago, and many of the community-based organizations, many of the participants and the members, they answered this question. And it was, where do you get your primary care? And they said they get it at their community center. And this is where they get their care. And so what we realize is that then we have to bring that to you. We have to bring those primary care physicians. And so now, as I talked about earlier with what we're doing with at Penn State, is and we've been doing this in Illinois as well, bringing those physicians from those primary care settings into those community settings, talking and discussing these health topics, these issues that are relevant to those particular communities or populations, has been a game changer. Because then those individuals know that when they show up at a certain primary care setting, that Dr. So-and-so is going to also be there because he's been in my community. And this has really been a game changer. And I think bringing people, out of the structure into the community is what's going to make the difference.
All right, well,
I would just add to that I think that, as Dr. Randall said, you have to sort of take research to the people. And for those, maybe that's not the primary care office. For example, homeless populations. I think that, there are initiatives with street medicine and homeless shelters. Those individuals, with good reasons, often don't have a lot of trust. There have to be other things there. They're not going to come just to be in our trial. They're going to come because they need food, they need, help with getting an ID, all of these things that are probably much more important to them than their health. And I think once you really sort of address their hierarchy of needs, then having clinical trials available there when trust is really established is going to be critical to really inclusion of those populations.
I really have got to add on with what Dr. Hodder says, because it's critically important what she said. Homeless populations specifically, you can pop into libraries in many large cities and you'll see a lot of homeless in libraries. We got a small bit of funding from NIH to drive something called the Research Literacy and Justice Project. And we pulled together 15 leaders in Georgia to better understand community trepidation around participating in clinical research in Georgia. And it was funded through the network of the National Library of Medicine. And librarians and libraries were they emerged as critical points for underserved populations, specifically homeless populations. They're trusted, they're there, folks are there, and we cannot overlook libraries.
Great. Thank you again to our panelists. We appreciate you joining us and for all the questions and discussion. Now going to hand it back over to Dr. Schwetz to introduce our next panel.
All right, great. Thank you, Felicia. We're going to continue in the same vein as we've had with this previous panel, but hear from the perspectives of clinical research networks and other federal agencies. As with the last panel, following the presentations, we're also going to invite the audience to continue to ask questions, and we'll probably go back to some of the ones that were kind of paused or skipped over in this last session to address during this one. So I just want to take a moment to welcome our panelists. We'll be asking each of them to present their vision of a successful network for research in primary care from each of their different points of view. So first up, we have Dr. Adrian Hernandez. He is the Executive Director of the Duke Clinical Research Institute and the Vice Dean of the Duke School of Medicine. He's a cardiologist who aims to improve health by accelerating clinical evidence through outcomes research, clinical trials, comparative effectiveness, and health policy. And he has led numerous large-scale patient-centered research programs, different registries and clinical trials across multiple different health conditions, including participating in the NIH's Health System Collaboratory and PCORI-funded PCORNet. He's also an elected member of the American Society for Clinical Investigation, the Association of American Physicians, and serves on the board of directors of the Reagan-Udall Foundation, connected with FDA. Dr. Hernandez, will you kick us off and let us know what your vision of success for this network is?
Yeah, well, this is terrific. And so I just, love the vision that was painted out earlier as part of this effort, which I'll translate to this vision of essentially getting research everywhere for everyone all the time. And I know one of the key things that we're aiming to address, and hopefully, those out there will be addressing directly, is really how to cover clinical trial deserts. They're both rural deserts as well as urban deserts, and it's very similar to what we see in healthcare. This illustrates the issue is that people are not conveniently nearby so-called healthcare settings all the time. And there are numerous healthcare deserts and even more clinical trial deserts when you consider it. And again, it's not just a rural issue. It's also you can have people in urban settings that are not conveniently connected to clinical trials. And so this is a way for us to see what happens here. I think one of the things that also will note is that I really appreciate what the NIH has done in so-called actually listening. When I first heard about this idea, I was wondering, will they actually listen in terms of the barriers that have been historically been in place for primary care-based research, noting that trust is a big issue. It's at the local level where trust is earned and maintained. It's also at the local level in terms of engaging people to meet their needs. And also importantly, a theme around developing sustainable financial models for doing this. And ultimately, hopefully all this can come together to so-called cover the clinical trial desert. Now, if you go to the next slide, also see that one of the things that has come up is that there have been trials historically where the participant met the site, where it was convenient for the site and convenient for the investigator and funder or sponsor. All that world has changed. We've learned a lot through COVID. Pre-COVID, everything was so-called site-based visits and care. People went to so-called the ivory towers, for instance, to get access to certain types of studies. Now that's changed where COVID taught us that there are a range of possibilities going to at clinic, at home, especially integrating curated electronic health data and using digital tools to link other data that perhaps people never thought was possible. So is it possible to actually do studies evaluating different food choices? Is it possible to evaluate different strategies in terms of what they may be doing for different mental health issues? And all this is possible by linking different approaches to make it more convenient for the person or participant in research. And now we do have this changed world of possibilities where a variety of technologies and approaches can be adapted to meet the person and the clinician where they're at. If you go to the next slide, also see that we have witnessed so-called the art of possible turning into reality. There are a number of platforms that have been developed over the last few years in what I call a click and mortar model for pragmatic clinical trials. You heard the vision of essentially letting primary care physicians or clinicians vote so-called what protocols would meet their needs or address their common clinical dilemmas. Likewise, we can see that patients or potential participants can raise their hands or literally vote, so to speak, in terms of what preferences they may have in terms of addressing their health concerns or health conditions. And so having the ability for touching or engaging literally millions of people across all 50 states who are interested in improving the health like them as well as others, letting them so-called vote to pick what's their priorities, being able to address those common health problems that they may have, and also uniting with clinicians who have the same similar common clinical dilemmas that one needs. So this is just a schema of a platform that has been done successfully where every state was covered via health system clinics or at-home approaches. And enrollment was done virtually or in clinic, and allowing patients to actually prefer of the different choices they had for a clinical trial to address an important acute respiratory illness, that they could actually have a choice. They could choose to be part of any of the arms. They could choose one or another. And everything was done seamlessly in terms of collecting data, and then also having tailored personalized follow-up depending on where they're at, and also what would actually fit with their routine life in collecting important outcome data from healthcare use, symptoms, patient-reported outcomes, and health and functional status. More importantly, if you have such a platform here, then you can return the results to everyone everywhere, because you've actually started at the beginning of noting all the people who would be interested in this health problem, even those who may ultimately elect not to participate, but feeding the results directly back to the clinicians who enable this, as well as the potential patient populations that would be interested in this. And so hopefully all this could come together, and what I would imagine or dream of is, can we get to a national randomization day as well as a national implementation day, so we're more seamless and building off the existing foundations that have been laid out before to enable this grand vision that's been outlined of so-called what I interpret, as I said, research everywhere for everyone all at once. So thanks, and look forward to the discussion.
Great. Thanks so much. I love that phrase, getting research everywhere to everyone all the time and returning those results to them. That's such a key point. Okay, so we're going to shift now to our next speaker. So we're also joined by Dr. Melinda Davis. She is a professor in the Department of Family Medicine and OHSU PSU School of Public Health, and also the director of the Oregon Rural Practice-Based Research Network and the OCTRI Community and Collaborations Core at Oregon Health and Science University. Dr. Davis is a participatory implementation scientist who collaborates with patients, community, and health system partners to adapt and implement interventions to improve health equity in rural and low-resource settings. Dr. Davis conducts her work in ORPRN, often in partnership with the Community Health Advocacy and Research Alliance, or CHARA, and Oregon's Coordinated Health Organizations, or CCOs, and other state and national partners. So with that very acronym-full introduction, let me welcome Dr. Davis.
Thank you so much. It's a pleasure to be here. And the maybe two acronyms to keep in mind are just PBRN for Practice-Based Research Networks and CTSA for Clinical and Translational Science Awards. And for my setting the stage for my vision, I'm going to start with two scenarios crafted from 2 decades of work conducting partnered research in rural settings. And that includes with clinics, communities, and health systems as introduced. I'll just start, I think there's a really exciting parallel for how we build trust with our communities, as well as how NIH is building trust with us as researchers and professionals now. And so some of what I'm going to emphasize in terms of our approach to community partnered research, I think is something I hope continues to play out in this initiative. So let me start with the first scenario. In this scenario, a seasoned researcher seeks to enhance diversity in their pragmatic clinical trial. They start cold calling FQHCs, or federally qualified health centers, across the state. After 6 months, they enroll one FQHC. After 12 months, over 200 patients have been eligible for the study, but only 5 were recruited. Moreover, the researcher is not able to access data from the clinic's EHR on these patients. The clinic medical director is frustrated and advocates to avoid studies with the researcher's institution. Okay, so let me give you scenario 2, which I think is supported by the vision of this initiative. In this scenario, the same researcher has a new project, but they now realize working with community clinics is outside their expertise. They present at the CTSA's design studio and are referred to a PBRN. Through a series of consultations, the PBRN team helps align the research question with priorities that have already been identified by the network's advisory board of clinician members. The researcher adds the PBRN director as a study team member, and they iteratively refine the study design to complement clinic workflows. The final application has letters of support from 4 rural health systems and funds both regional PBRN staff and clinic impact fees. Following funding award, the PBRN team re-engages the interested health systems, or more appropriately, reapproaches. They've been engaged the whole time. Within 1 month, the same FQHC agrees to participate. Within 3 months, PBRN staff have updated the clinic's EHR to support data tracking and queries and start to initiate enrollment activities using both visit-based and community outreach strategies. Notably, PBRN staff are from and of the community. They have worked with the FQHC and community partners on prior projects and have facilitated resource connections to address other partner needs, including clinician recruitment or educational training. Within 9 months, the participant recruitment target has been met and diversity criteria exceeded. This has all been achieved despite transitions in the medical director and multiple clinic staff. The project is celebrated by FQHC leadership, who have integrated the intervention as part of routine care and are eager to partner on the next study. So I share these stories and scenarios to highlight how academic community collaborations can either strengthen or erode partnerships. Hopefully you were able to see a few key patterns that support successful bidirectional relationships. And I'm going to highlight just 5 that I think are really important. So the first is to leverage existing infrastructure and relationships when possible. This is especially important in rural communities where we need to be encouraged not to build parallel silos. Second, engage with clinic and community partners before there's any ask. Show up and understand the players, not just what their jobs are, but who they are and what they care about. Third, it's important to resource infrastructure in and from both the clinic and community that is sustained beyond individual studies. And you've heard this as a principle in this initiative. Luckily, we already see this often in PBRN programs through the use of their regional practice facilitator model, or in CTSAs through community research liaison roles, both of which can serve as a boundary spanner between kind of the academic environment and the communities and clinics they serve. The other, I think, important caveat of this is that for some clinics, building infrastructure isn't necessarily sexy or flashy or innovative. It can really mean helping develop their EHR systems to be able to produce data queries and securing adequate staffing to deliver basic clinical care. It's important to recognize that we need to use an equity approach with our clinic engagement strategies, not just an equality model. Fourth, develop processes to listen and facilitate connection to address partner needs, even when they're not aligned with your specific research agenda. And finally, recognize that sometimes a positive outcome is not necessarily clinic engagement in a study or a trial, but it's really about having the opportunity to discuss, learn about concerns and needs, and come a step closer together to align on the next opportunity. So I think these types of efforts, like the one initiated today by NIH, is critical for building and maintaining trust, developing shared research agendas, and having the appropriate foundation in place to turn around to funding requests with short submission windows, like the one many of you may be responding to in relation to this initiative. I want to end with one final anecdote. About 10 years ago, I had a career development award that was focused on building a pragmatic coaching model to engage rural communities in research. When I presented this project to a room full of senior faculty, one asked, "Do you want to do good or do you want to do research?" which generated a robust chuckle across the room. I didn't have a great response at that time, but now I like to share this story because I like to emphasize what I wish I would have replied, which is, I want to do good by doing good research. I hope you do too. I'm grateful for initiatives like this, which have helped make this vision for creating trusting, bidirectional research partnerships with rural primary care clinics and communities possible. Thanks for the opportunity to share.
Thanks so much. I'll now turn it over to Dr. Jeanette Dupuy. She is the director of the Quality Division in the Bureau of Primary Healthcare at the Health Resources and Services Administration, which we refer to as HRSA. Her division leads key programmatic quality improvement efforts for the National Health Center program, and she's a psychologist by training. So Dr. Dupuy, I'll turn it to you.
Thanks so much, and it's such a pleasure to be here with all of you and representing HRSA, in particular the Bureau of Primary Healthcare. I just want to start with like a 30-second overview of the Health Center program. Hopefully most of you are familiar with what the Health Center program is, but we provide primary care to roughly 23 million patients across the nation, represented by over 1,300 sites, and this is comprehensive primary care, including oral health, behavioral health, and as mentioned throughout this entire, so far the hour and a half that we've been together, the importance of including vulnerable populations in the research that is being done, and that is specifically what the Health Center program is. We focus on the nation's most underserved and vulnerable populations, amongst those special populations as well. I heard some mention of the homeless, migrant, public housing is something, another area that we focus on as well. So we truly understand what it is to serve the nation's most vulnerable and providing that comprehensive, holistic care that every patient deserves. So with that being said, why is this important to us here at HRSA? Primary care serves as the entry point to healthcare, and in most instances, it's important to understand what is happening in primary care settings because of that. It's important, as we are talking about research, to make sure that the research that is being conducted is representative of those that it is trying to be applied to. Many times, and I'm speaking for the Health Center program, we don't see a lot of research taking place. In particular, health center patients are not part of clinical trials, and this can lead to research findings that are based on a non-representative sample. And so we really can't apply sometimes many of the findings that we are seeing out there to our patients. So what would a successful research network look like for us? I think one of the main things is minimal disruption to clinical care. I've been keeping an eye on the chat, a lot of great questions and comments coming in, and that's something that I've seen in the chat. Comments such as, this is great, this is important, but we simply don't have time to do this. So I think as the research is being developed, keeping that lens in that primary care providers are strapped. We understand the massive burden on the workforce right now across the nation. We see it a lot in the Health Center program. And so adding one more thing to the plate, many times a provider trying to fit this into their day is just not realistic for them. So I think that keeping that in perspective as research is being considered is very important. Another thing that is important, I mean, I've heard this discussed a lot already in the previous panel and also comments throughout, is the importance of utilizing data correctly. What are we going to collect? I know something here in HRSA that we always say is, What are we collecting? And then what are we doing with what we collect? We can't just add burdens to another burden to our providers, to clinicians, to staff. There has to be a why, a thoughtful why behind that. And what data do we already have that we can utilize? In particular here for us, is it the UDS data? Are there cohorts of data in CDC or NIH that we can utilize? And then how can we build upon that? And then drilling down to the ground level, how are we using the EMRs and charts to make sure that the data that we're utilizing is we're not adding additional burden, and how do these cross and compare to one another as we are trying to see the results that we are trying to get, and making sure that what is being collected represents the patients that are being served. Another thing, and this is something that I mentioned over and over and over, social determinants of health. We can't have conversations about research. We can't have conversations about technical assistance. We can't have conversations about primary care if social determinants of health are not at the table. In particular, for the health center program, truly understanding the uniqueness of the patients that we serve. Many of our patients have multiple chronic diseases. How is that being considered? How is that being played into whatever research is being considered? I think one of the previous panelists, either Dr. Davis, mentioned something about community partnerships, and that is so huge, so important. Having the right stakeholders who should be at the table. Also within the chat, there's been a lot of great comments on this as well. What are the right providers? Who are the experts? Who are the right experts that should be included? Is it physicians? So all of that I think is super helpful. I know I'm taking a lot of notes, in particular what I'm seeing in the chat, to bring it back to HRSA to make sure that as we're hearing from all of you all, what are the things that you think make success in research? Those are being considered as well. I think another thing that is important is understanding not only focusing in on what's the immediate ask. Let's say we want to do research on X topic, but being able to lift our head and see what is the context of what's going on. We could go back to the pandemic and see how anything that was being done in that particular time frame of society, the data will look very different. Data will never be the same because of COVID and previous years. I know it greatly impacted a lot of the data that we collect here at HRSA, but having that context in mind, how did whatever's going on in society, whatever's happening, whether it was the pandemic or anything that may be going on multiple levels, how does that impact the research that's being done and also the results of the data? This has been mentioned over and over, but I do want to reiterate, trust is so important on multiple levels. There is such a hesitancy right now, both from the patients and then beyond health centers as well. We don't want to engage in this. What is this for? What are you trying to do? We don't have time. They are very protective of their patients, and we love that. And so transparency and trust, I think, is very important. Being able to, this was another comment from you all are the experts, those that are typing into the chat. This was another comment. Is there a genuine transparency? Those that are going to participate in the research, do they know? Like, what is this research going to do? Are we closing the loop after the fact? With the patients, with the clinicians, with the community centers, with anyone who's being involved, that true transparency and trust, I think is very important. So in summary, I think to keep in our thoughts, it's important to have the right data sources. Ask ourselves, do we really need to collect these 10 things, or could we collect these 3 things? Is that going to be a burden to those that we are asking to be involved in? Making sure that the sample is representative, and to be able to have that access to that sample, making sure that there is trust and transparency, and to be able to access that population that we are trying to focus on. Understanding the context and the nature of what's going on in society on multiple levels as we're trying to research, because that's going to obviously impact the results. Social determinants of health, closing the loop with patients, clinicians, and also actionable findings, and of course, recommendations. What's the next? What we collected this, we did this, then now what? I think that's very important as well. So I'll stop there. Thank you.
Great. Thanks so much, Dr. Dupuy. I mean, yeah, that it's you echoed many points that we've heard numerous times throughout the course of establishing this and holding various different listening sessions, particularly about provider burden and how we can balance that out and try to provide the right incentives and address the questions that are most important to them and their communities. Okay, rounding out this great panel, we have our final presentation from Dr. Amy Eden, who is the acting director of the National Center for Excellence in Primary Care Research at the Agency for Healthcare Research and Quality, or AHRQ, or AHRQ. Dr. Eden is a medical anthropologist and quality researcher with a background in public health and international development. And she previously was a senior research scientist at the American Board of Family Medicine and conducted various mixed methods research projects on the experiences of the primary care workforce and trends in primary care training and practice. So Dr. Eden, let me turn it over to you.
Great. Thank you so much for having me. And I would just like to start with a little note that I'll be using NICE PCR to abbreviate the mouthful that is the National Center for Excellence in Primary Care Research going forward. So to present an AHRQ vision of a successful network for research in primary care, I'm going to draw on two sources. First, NICE PCR's definition of primary care research, and then secondly, AHRQ's 4 decades of work with primary care practice-based research networks, or PBRNs, as Melinda said. So NICE PCR has developed a definition of primary care research which builds on Barbara Starfield's 1996 assertion that the only meaningful definition of primary care research is research that is done in a primary care context. But given how that context has changed quite a bit since the 90s, as Dr. Hernandez so nicely illustrated on his slide, our definition expands on that notion, defining it as research conducted for the purpose of better understanding or improving primary care, and a little more specifically, research that is conducted in a primary care setting that is about primary care patients, clinicians, or teams, and is on a topic that's integral to or has direct implications for the delivery of primary care. So from this definitional perspective, a successful network would really ensure that the clinical studies selected are ones that are important for primary care patients, clinicians, and teams, and that they have the potential for real and positive impact on the quality of primary care when translated into practice. Given NICE PCR's role in primary care research, we are especially interested in study designs, protocols, methods, or measurements that really consider how the clinical research might impact or be informed by the foundational elements of primary care, which is the place of first contact with the health system for most patients most of the time. It's also continuous patient care over time. And of course, it's coordinated, comprehensive, whole person-centered care. And making these connections between the studies and the nature of primary care may really serve to improve recruitment, engagement, and the commitment of primary care practices and their patients and their communities over time. And I would just want to add that while our definition of primary care research doesn't specify who conducts primary care research, to us, a successful network would really help to build and support the primary care research workforce, including physician and clinician researchers, social scientists, et cetera, by ensuring the inclusion of primary care researchers on every study team. And then second, drawing on what AHRQ has learned from its 40-year-long relationship with and support of PBRNs, I would absolutely reaffirm what Dr. Stabler and we just heard on this panel from Dr. Davis. They've already mentioned so many concrete things. And I'd really propose that the structure and unique approach of PBRNs really serves as a model of what success looks like in conducting real-world, community-based research in primary care practice settings. And even with some of the methodological differences between the approaches of traditional NIH clinical research and PBRN research, we believe that the NIH network has a lot to learn, and thankfully you are, from the experience of PBRNs. Like PBRNs, a successful NIH network would be guided by practicing primary care clinicians who are really keenly aware of the clinical issues and needs of their patient population. And really, who better to identify the research questions that need answers on the front end, but then also to ultimately implement those research findings and the evidence into practice at the tail end. So I just will conclude by saying that we at ARC are really excited to see the NIH devoting this attention and these resources to primary care, and really appreciate, like others have said, the intentional listening to all of these relevant communities to develop the initiative. By ensuring that communities underrepresented in clinical research are routinely included in clinical trials, this proposed network has the potential to make important contributions towards understanding how to equitably diagnose and treat and manage patients where they most often interact with the health system, which is in primary care. And as the agency charged with improving healthcare delivery, we at ARC really look forward to working with NIH to ensure that research findings from this initiative are understood and used in primary care throughout the country. So thank you for having me again, and I look forward to furthering the conversation. Thanks.
Thank you, Dr. Eden. That is such a great point that you ended on, making sure that the research that we support gets translated into clinical practice. That's really a key component of this effort as well. So thank you all for sharing your vision for success. We'll now address some questions from the audience. So please continue to input your questions into the Q&A box. And as you're submitting your questions, we'd also like to take the opportunity to hear from you via a quick poll again. So just as you continue to answer these questions in the poll, just a reminder that due to some of the Zoom logistics, the results are not going to be shared here, but we are definitely going to consider them, analyze them, and try our best to incorporate them moving forward. Okay, we'll give everyone another few seconds to complete that. And so while you continue to submit your questions and respond to the poll, I'd like to welcome back Dr. Stacy Adam to help us moderate the questions. So Stacy.
Thank you, Dr. Schwetz. Yes, I mean, given the broad reach of this group and the focus on networks and kind of what the federal agencies can support, thought we might tackle some of questions about a particular one. How might a successful applicant address the lack of primary care providers in rural settings? In particular, the number of PCPs retiring seems to exceed the number of new people coming into these communities. Would this group have any suggestions about how folks, looking to help with care for health might address that particular issue?
Who wants to start? Well, I know I'll say one thing quickly while folks are thinking about this question. I do think we've heard this a couple of times to date. Not going to address the acute issue, but longer term, one potential benefit we hope of this network, which is not necessarily a direct goal of it, but I think a secondary outcome that we would like to see is that providing these opportunities for more research to primary care providers may allow that to serve as a recruitment tool for some people to enter into those primary care settings in rural communities. So that's kind of a down the road. We'll see how this evolves approach. Adrian, please feel free to elaborate.
Yeah. I think it's an important question. I also noted, through the chat that it's not just, the availability of primary care physicians in rural settings, but they also have a really busy day and night often. And so how do you fit this into their world that they have clinical dilemmas that they're being addressed? And so, one approach that has worked in the past is, allowing people to focus on what they're best at and what's available in terms of that patient engagement interaction, and be able to use other approaches that unburden them for actually participating in research. So there are many models that have been demonstrated in terms of centralizing some of those aspects that are I'll just call it the administrative burden that the large healthcare systems often carry. But how could you allow the rural physicians to participate, engage, and do what they're have their best at, and also have time availability for it, and then so-called allow the other parts of the system to take on that research burden of the administration process. So I think it's possible if we have the governance to do so.
I would just add, in our experience in ORPRN, a number of our clinicians in rural areas have actually said participation with a PBRN or in research studies is often a lifeline. It creates an opportunity to kind of step out of the day-to-day and really contribute to a bigger generalizable mission and feel like you're having an impact beyond that individual direct patient care. I think it's not just providers we need to be thinking about, though. It's also staff, as some folks mentioned. Staffing transitions have always been a challenge in primary care, and I think those have been amplified in the wake of COVID. The other thing I think that's important is realizing that a lot of these networks, we're not just doing research. We might have arms that are focused on educational outreach. We might have arms that are focused on kind of health policy implementation. So a lot of what the networks are doing is not just research, but really trying to help resource and build infrastructure in these primary care clinics so that they can retain and maintain providers in their clinical teams. And this may be beyond this initiative, but I think a lot of this is not just for the research enterprise to solve, right? A lot of this is also about advocating for reimbursement policies that appropriately resource and support primary care clinics so they have the robust infrastructure in order to deliver care, and then leverage kind of research on top of that. And so we've often seen that the most productive primary care partners are those most able to engage in research studies, are also those that have the best kind of financial model business line. And that's, I think, getting harder and harder in our current system.
Excellent. Thank you all. Building a little bit, and Adrian, you talked just a moment ago a little bit about burden. We've had a number of questions that sort of center around what is the role in this particular network, and do we foresee that there will be a buildup of it, of mobile health technology, kind of implementation of tech, maybe even engagement of alternative sites such as CVS and others. And so these, new innovative alternative models, how do you see that playing into the role of relieving that burden, or helping to relieve burden, and even to some extent addressing what Dr. Davis just talked about staff turnover? If you could have a centralized remote folks doing that for the primary care physicians.
Yeah, I think it's very well possible. And so, again, adapting to kind of what the, clinical questions and, how they're being addressed and the study needs there. And so there are many things that, can leverage technology, adapt to the situation, so it can be more seamless for the user experience, the patient experience, as well as the clinicians and staff. And, just noting like some of the comments about, 9.5 hours that people have, the staff turnover. And so we wouldn't want to have a system, I think, that burdens them, but actually alleviates the burden. And that can be done through different centralized methods or technologies for the various networks. And, I've seen, a variety of networks out there that have started using that. And again, hopefully getting greater engagement at the point of care to allow people to have freedom to do what they want to do.
Does anyone else have thoughts? Amy?
Yeah, I'll just add that, you know, there are a lot of newly developing technologies and models of care delivery to the point that younger generations don't even have a primary care provider. A lot of that might have to do with not just access issues and the changing nature of how people seek care, but also, you know, their health tend to be healthier younger people. And so just, you know, sometimes new models and new technologies that aren't quite yet tested can undermine, I would say, some of the, you know, the Starfield 4Cs of primary care. And so if we're really thinking about true primary care research, just keeping in mind, you know, our patients in those other settings receiving care from Walmart or urgent walk-in clinics, are they getting true primary care? And what does that mean then for, you know, trials and care coordination for, you know, the various conditions that people have? So.
Well, one other comment, Stacy, just on that is that, like, I think everyone has kind of seen the changes in terms of, you know, there's a lot of great ideas around the CVSs around every corner, so-called, you know, 11 miles near every potential person in the U.S. But I think the one thing that, you know, was missing and why it didn't quite work out as planned is that, you know, trust is very much at the local level with the primary care physicians, the PAs and nurse practitioners, the clinical pharmacists, whoever that patient is normally seeing. And that established relationship is really important for this effort. And it seems like that's a theme that's, you know, coming out that this is why this is going to be really critical to have the people who are on the front lines engage from beginning to end.
I'll just briefly share. I think it's an important point to think about, as Amy said, how we integrate that information. A number of years ago, we did a study about rural primary care views toward using remote monitoring technology to care for their patients. And one of the key qualitative themes was, we don't want to spend more time reviewing the data than we get to spend with our patients. And so I think, again, this is where, when we're co-designing studies, we need to make sure that those studies are in alignment with workflows. And there have been a lot of questions in the chat about thinking about resourcing primary care or engagement. And I think what a number of us have alluded to is this need for complementary structures or supportive structures. And I do think data and artificial intelligence plays an important component. But again, there's a lot of foundational investment that needs to happen in these practices to make kind of the vision of this research network feasible and not to exacerbate disparities, because there's definitely a tendency to go to sites where they have infrastructure and capacity, and that can maybe not necessarily represent the full population that is served in primary care across our country.
Yeah, I think, and Tara, or Dr. Schwetz, if we have another chance for one last question, I think we keep hearing a reoccurring theme that has both come up in the questions in the chat as well as from our panelists, and that is resourcing and the continuity of resourcing and how we are going to get that to the right places in primary care. Do yourself or any of the panelists want to weigh in on what we think the best way to address that is, right? To make sure that we are resourcing these sites appropriately for how we're going to begin expanding out and asking them to assist us in this clinical research.
Well, I'll let the other panelists kind of elaborate on the right level of resources. But one thing that I will say is that, you know, one of the things that's really important to the development of this network is that sustainability. And we keep saying, we want to make something that's sustained and sustainable. And So we're thinking about that really at the forefront as we're playing out this effort and trying to, budget prioritize over the next few years. The other thing I would say is we also recognize that there needs to be flexibility built in to help, as we evolve with the development of the program, as it continues to expand and grow, but also as we learn more about how this will function, what the needs of the communities are. And so some of the mechanisms that we're utilizing should help us to enable that flexibility a bit. But I'd love to hear from the other panelists.
Well, I can jump in really quickly. I don't have the right answers, but I know from ARC's PBRN experience in the past, finding the appropriate funding mechanisms to fund practice, primary care practice and community organization and patient engagement from the beginning, from those planning. So, how do we fund planning stages, the capacity building, dependent on what the needs are in the community or in the practice, building research infrastructure, all of those things might need a little more creativity. They don't fit in the normal research project funding cycle. So, how do we incorporate that and set them up for successful participation in research?
You raise a great point about capacity building. Part of what we're doing with this program is trying to leverage some of our existing infrastructure that we have in our existing networks that are building up that capacity. Adrian, please.
Yeah, no, having examined that kind of financial model for these types of things in the past, I think, two things come up is ensuring there's a portfolio that matters. So meaning that there's enough studies that, can cover what's needed for a primary care based research network and the various clinics. You can't go at this in the onesies and twosies. So if, getting a grant and it going away, that's not going to work. That ties into the other thing. And, again, primary care colleagues often say capacity planning is really important. They can't just hire someone tomorrow. They're trying to meet the clinical needs of today. And so having kind of that long runway and understanding capacity planning is really important. So again, it ties into a portfolio and, at least, the forecast of all the different issues that need to be addressed is, I'll just say gloomy. So it's really important here to have that portfolio match what's needed in the future.
Maybe have just a few thoughts. And again, like Amy, don't have the answers, but hopefully we'll learn some commonalities in this initiative. But I think one of the things we've really learned in our network is that this is where it's important to know the sites. And so obviously resourcing clinical partners is important, but in some settings, let's say if it's a larger health system, they may have clinical team members or a research division. And so you may choose to staff and resource one of those existing team members. If it's, say, a smaller independent practice or a more isolated practice, they might not have that same infrastructure. And so you might actually want to embed research team members to support the process. The other thing we've really realized is that the allocation of funds or clinic impact fees, maybe it's good to have flexibility there in the sense that sometimes clinics want to use that to buy out specific FTE. And we've also seen sometimes clinics use that money to put a new roof on their practice because that's where they needed the resources to go. So I think a lot of this just goes back to the need to not just be thinking about our research enterprise, but also what's the broader financial model for primary care success. I think the other thing that's really exciting, and this is also in the chat, some of the new mechanisms and requests for applications that are coming out of the NIH and other partners where they're focused on things that matter, like social determinants of health and behavioral health integration. There is a very exciting shift, I would say, in terms of what's being supported in our federal research. And there are lots of exciting opportunities that complement this initiative. So we're at a really good point. It's exciting to see all these, I think what I assume are practitioners in the chat who want to get involved. And so really excited to see how we can learn and help facilitate the ability for partners to participate effectively.
Great. Well, I think we're now going to transition to the next session. But before we go, we're going to ask for your input on another poll. So that should be popping up here just for your input here about the types of studies you think the network should be focused on. And so while you're filling that out, I just want to take a moment to thank you again for the panelists. That was a great discussion across this panel and the earlier panel. Really appreciate you joining us. And I'd now like to welcome Dr. Amy Patterson, who is the Interim Scientific and Medical Director for Care for Health. And she's going to give us a little bit of information and insight into the path forward for the program. So, Amy.
Good afternoon, everyone. Thank you for participating today as we launch this new program. During this portion of the meeting, as Dr. Schwetz said, we'll be reviewing the overarching aims of Care for Health with a focus on the initial planned approach and timeline. And I'll say up front that this is a work in progress, and we look forward to working with you as we shape the program moving forward. Next slide, please. As Dr. Bertagnolli and our panelists and people in the chat have underscored, there's a critical need to extend research participation opportunities to communities that are medically underserved, disproportionately impacted by disease, and underrepresented in clinical research, and to offer those opportunities for research participation in local settings where people seek care. The overarching goal for us is just routinely conducted in primary care settings, such that the fruits of this research can help advance clinical care and are applicable across our population. Based on the input that we've received so far, and including today's discussion, we know that to be successful, this effort that we're launching today needs to be practice-based and patient-centered, meaning that practitioners, their staff, patients are all our partners in planning the research. To address the need to extend research participation opportunities, as you've heard, we're beginning to establish a primary care-based research network of networks, if you will, one that is disease agnostic and is intended to facilitate clinical research across clinical conditions and across the lifespan, addressing both prevention and treatment and dissemination and implementation. This network will strive to facilitate and embed innovative research into routine clinical care in real-world settings, and to emphasize and enhance dissemination, return of meaningful, impactful results to practices, to patient communities, to enhance implementation of effective care strategies. This network's also going to aim to create a foundation, as many have touched upon, for sustained, active, bi-directional, and ongoing engagement and partnerships with primary care clinicians and communities. Next slide. The approach we're taking to begin this effort is first to move toward a rapid launch, just to get going, partnering with extant clinical research networks and providing resources for them to expand enrollment efforts of some current ongoing NIH studies that they will select and that align with the health conditions of relevance to and are prioritized by primary care practitioners and their local communities. And as the enabling and supportive infrastructure is established over the next year, we'll also begin to pilot new studies and expand the network of networks with new collaborations. To ensure that the program is indeed practice-based and patient-centered, we will be engaging primary care practices and their community partners in prioritizing, planning these new research studies. And together we'll develop and implement new studies using fit-for-purpose methods and technologies that are designed to minimize the burden on patients to not disrupt the workflow of the primary care setting, but are also designed to maximize the value of the research, or as Dr. Hodder put it, be truly impactful research in the context of primary care. Next slide, please. Fortunately, and as many people have alluded to, we don't have to start from scratch. There are a number of outstanding efforts already underway to advance primary care-based research. Many partners, as shown here, groups, organizations that we need to continue to engage and hear from. And we look forward to forging multiple partnerships and to really learn from this significant collective expertise and experience as we work together to build a national scale effort, a national ecosystem here. We anticipate that the scope of partners will expand as the program grows to build a really sustainable foundation, starting with some collaborations with several ongoing programs. These include, for example, the NIH All of Us program, the IDEA Clinical Trials Translational Research Network, the Community Engagement Alliance, or SEAL, the Clinical and Translational Science Awards programs, or CTSAs, and the NIH Collaboratory, as well as PCORI's Patient-Centered Clinical Research Network, or PCORNet. We have a number of initial key federal partners, several of whom are represented in the meeting here today: HRSA, AHRQ. We also have reached out to the Indian Health Service, FDA, and CMS, recognizing their important roles in this space. And again, expect this partnership to evolve and expand over time. Next slide. The Care for Health program is led by several members of the NIH senior leadership team, and it will be co-led as we develop it further by leaders from the primary care and patient-led communities. Several of the NIH leadership members you met earlier in this meeting, Dr. Helene Langevin, Dr. Joni Rutter, and Dr. Deb Tucci, who, in addition to serving as directors of their respective institutes, also serve as co-chairs for the Care for Health Oversight Committee, alongside Dr. Tara Schwetz, who you've met today, who serves as the director of the Division for Program Coordination, Planning, and Strategic Initiatives at NIH, which is the home, as many of you may know, of the NIH Common Fund. Next slide, please. In terms of timeline for this new program, we've been working over the past few months to obtain a broad range of perspectives to inform planning. This has included a series of preparatory listening sessions that Dr. Rutter summarized, and of course, today's workshop. A research opportunity announcement was published on May 6th in support of the early development or pilot phase of the program, and it's currently open through June 19th. During this pilot phase, we'll jumpstart the program by partnering with some existing clinical research networks and expanding existing NIH studies to increase engagement with underrepresented rural populations and enhance accrual and collaboration. We'll also be engaging primary care sites and their community partners during this time to prioritize and plan future research. Care for Health is being administered as an NIH Common Fund program, and it's launching with a budget of approximately $5 million in fiscal year 24 and $25 million in FY25. Looking ahead to 2025 and beyond, we'll be working together to co-design and launch new studies across the network, defining measures of success, and further establish and solidify the network infrastructure. I did want to underscore that while this initial research opportunity is focused on research in rural communities, we expect the scope of the program to expand as infrastructure is developed to encompass the full range of populations, with a focus on those underrepresented in research, regardless of location. Next slide, please. The current research opportunity announcement invites applications from specific clinical research networks, as well as organizations currently participating in those networks, to serve as what we call network research hubs. The hubs will initially expand accrual efforts of select current NIH-funded studies that align with their interests and priorities and engage rural practices and communities. These hubs will also develop and conduct new studies in partnership with local practitioners and patient communities, so that Care for Health research studies align with local primary care priorities and utilize innovative clinical study designs that minimize burden. Now, in developing and implementing these new studies, The hubs will collaborate with an enabling infrastructure. Next slide, please. That will be developed by Care for Health during the next year. And we look forward to working with you in the primary care and patient communities as we design and establish this resource. We envision the infrastructure as including several key components as depicted here, but will be intended to foster and facilitate research in primary care settings in a flexible, fit-for-purpose way that is responsive to local practice needs. Notably, this NIH-based infrastructure will include providing resources to facilitate sustained patient practice and community engagement. And this will be done in part through partnerships with a number of programs such as SEAL and All of Us that were previously mentioned, and others that already have robust efforts in this space. The infrastructure will include, for example, a clinical science center to enable and support the development of clinical study designs and implementation strategies that reduce burdens on sites and participants. It will provide oversight of the new studies and statistical and data management support. The infrastructure will also include an operations center that will, for example, conduct site feasibility assessments, help support forging site agreements, help coordinate study operations, including protocol refinements, compliance with regulatory and participant protection requirements, help with communications, training, data monitoring, and a variety of other activities that might be needed. The program will also provide review and oversight by independent review and monitoring boards. And finally, it will also provide opportunities to explore and will facilitate partnerships with the private sector as needed. Next slide, please. So to wrap up, during this 2-year pilot phase of the Care for Health program, we have a critical and challenging mission. We're looking forward to engaging you and other partners in this effort. During the first year, we'll fund the network research hubs that will participate in select existing studies. These studies may be interventional or observational and are expected to be suitable for primary care settings. During the second year, new research studies will be co-designed in coordination with the other components of the infrastructure. And before the end of year 2, we'll evaluate which approaches and efforts are working, which ways we need to pivot, and what will be suitable for broader implementation. Next slide. So in closing, the listening doesn't end today. This is only the beginning, and we look forward to working with you and learning from you, not only about what we do, but how we do it as we shape this program. For those of you who'd like to learn more about the program, there are a number of additional information resources on the Care for Health website. You can quickly access it using the QR code shown here. And now I'll pass the baton back to Dr. Schwetz, who will open us up for questions. Thank you.
Great. Thank you, Dr. Patterson. I think we're actually going to have Dr. Cashew come on and help us run through some of the questions for us to try to address today. So Felicia?
Yeah, we'll try to get through a few questions that have been coming in through the chat. We've have a big broad question about scope. So will the Care for Health network be focused on any specific research topics? Yeah, maybe Amy, you can address that.
Happy to, Felicia. The scope of the research topics will be broad. They will be driven by the primary care clinicians and their patient communities.
Yeah, we like to refer to it as we're pulling together a menu of studies that the sites can choose from based on the needs that they have in their own communities.
So there's a lot of enthusiasm in the questions for primary care clinicians and organizations to really be involved and engaged in this effort. So can you speak a little bit more to how these primary care sites will be part of the Care for Health program?
Amy, you want to take that?
I'll start off and others please jump in. Well, first and foremost, we will be selecting in these initial network research hubs ones that have a proven track record of effectively engaging local communities, local practices. Secondly, as we assemble the infrastructure and the governance for the program, we anticipate representation from various groups as part of the team that will develop the research agenda, the research protocols as we move forward. And I also anticipate that we will regularly convene listening sessions and other venues for getting ideas from practitioners on the front line, engaging some of the professional societies that have a deep interest in this topic is also very important to us in reaching out to them. And if people on the call today have ideas about that and how to go about it, we'd be very open to it. Thank you.
Great. We have a couple of questions about pediatrics. One member of the audience noted that children aren't little adults, so the pediatric primary care environment faces unique challenges and obstacles, and will pediatric primary care research be part of the program?
Absolutely. Yeah. It's a major discipline. It's a major population. So where prevention needs to begin, in addition to healthcare. So definitely pediatric studies, pediatricians, pediatric care practices, definitely part of the program, important part.
Yeah. And I just spoke to the American Academy of Pediatrics, a group that they have last week, and got some really great feedback and insights from them for how we should begin to, or continue, I guess I should say, to think about incorporating pediatrics into this study. And we can take some lessons learned too from some of our other efforts that we have across NIH, and in particular things like the ECHO program that's studying environmental influences on child health outcomes, and they have a clinical research network where they're partnering with our idea states to run some trials, as well as the All of Us program, who's been preparing to hopefully launch PEDS soon as part of their efforts. But also, we have partners across all at NIH, including NICHD, who are experts in this. And we've got folks on our group, and we'll continue to think about ways to build in experts into sort of our community fora, that we make sure that we continue to hear feedback about how to think about incorporating PEDS.
Great. All right, gonna kind of switch gears a little bit and talk about engagement. So one audience member noted that they've heard some concerns in the community that recruitment is the specific form of engagement, and wanted to ask, are there plans to ensure that there will be a focus on community engagement that goes above and beyond just emphasizing recruitment efforts?
Yeah, when we've already talked about a few things. Obviously, taking an approach where we're addressing the challenges that are of importance to the community, I think is one aspect. I think Amy showed a slide that illustrated many of the different things that we're thinking about trying to leverage and incorporate as part of this process across NIH. One of those resources is our Community Engaged Alliance, who's been doing this now for several years. Started with COVID, has shifted and evolved, and they have a primary care component as part of that. So that's another example of some of the ways that we've been thinking about this piece of it as well, because we want to make sure that that's what the question implies is not what we're trying to do here.
Yeah, it would just add to what Tara said, that I think for this program, recruitment is a downstream, and it's a potential outcome of engagement, but the community engagement that we're envisioning here, as experts on this panel and in the audience today know far better than we do, begins way upstream. And the first and foremost goal is to engage, and that has many benefits of raising awareness about health issues, learning about what the priorities are, And if that results in recruitment, that's wonderful. And it is an aim of this program to engage and recruit, but there are many upstream goals that have to be achieved before and are a prerequisite for recruitment. Over.
All right, maybe just one more question. One member of the audience wanted to hear a little bit more about data quality. And there wasn't anything more specific about that. And you know, we're in early plans of the program around any data infrastructure, but maybe you could speak to the importance of maintaining rigor in the studies that we do, and that a part of that is data quality.
Amy, you want to take that, and then I'll take a different angle on it.
Okay. All right. Well, we couldn't agree more with the comment. I think there's also a balance between leveraging data that is routinely collected in the clinical care setting, and in addition to other data that would be required for the clinical research protocol. So we'd like to leverage as much as we can EHR and other data that's collected by clinical care settings. We do very much want to emphasize that the studies that we put into the field are methodologically rigorous and, you know, have sound designs, so that at the end of the day, we have results that we can hang our hats on. But Tara, did you want to talk about sort of the data science and data efforts that this program is also going to be running parallel to?
Yeah, and I'll say, you know, in the first year, right, we're gonna I mean, this is expanding out existing studies, right? So it will look a little bit different than moving forward. This first year, we're just going to leverage the data infrastructure that exists with the studies that we're going to be, you know, sort of incorporating into the program. You know, going forward, we do hope to build out sort of a data management structure here. But in parallel to this program, one of the other priorities of Dr. Bertagnolli is actually data, and helping to employ a sort of federated architecture to improve you know, kind of our ability to work with and share data is really critical to that. And with a focus particularly on sort of extracting data from the clinical care environment to be able to utilize it for multiple purposes. So for research for sure, but also for, you know, epidemiology and other purposes across that are relevant to agencies across HHS. And thinking about how we can do that in ways that help to reduce the complexity, that minimize costs, and help to improve access, and that are really more flexible and agile in terms of sharing data and using and data standards. So these efforts are both very nascent and running in parallel, and we do see sort of intersection down the road.
That was a great opportunity to add the data science component. Well, I think we're at time. So Dr. Schwetz, do you want to turn us out?
Yeah, absolutely. And I'll be quick because I know we're 2 minutes over. So thank you so much for all of the really thoughtful questions and a few suggestions too that we got in the Q&A chat. Really great. And, you know, I think really echo some of the things that we've heard before, but also there are some new things in there that we'll take back and consider. And I really appreciate the panelists for their excellent thoughts and feedback that they have provided as well. Again, we know that there are we got lots of questions in the chat, and we weren't able to cover everything. We again hope that this is going to continue to be an ongoing dialogue, so that we can get input on this network as it continues to grow and evolve. And so just to stay in touch, if you have additional feedback that we weren't able to get to today, please feel free to send it either through the Slido QR code that is here, or you can go to slido.com. You can also visit the Care for Health website that has additional information. You can reach out to us at the website, or excuse me, the mailbox that is on the slide. It's also on the website. And you can join our listserv and stay updated on information as it comes out. So thank you all again for your time and interest and thoughts as we consider to how we are going to move forward with this network. And we really appreciate all of your contributions. So with that, the Clinical Research and Primary Care Public Workshop has concluded, and a recording of this webinar along with the slides are going to be posted online. So thank you all.